Good afternoon, and welcome to the discussion. This is a discussion about the realities of life, family, community, and our world. And this is a discussion about dementia and a chance for you to dialogue with four individuals that have very different backgrounds and yet share a very common and unique bond. The thing they share in common is not that they have worked together, they went to college together, they're friends from way back, but instead that they each have a passion and are committed to helping individuals facing dementia along with their families in leading and having a quality of life. They share a vision for well-being, that every person deserves to be respected and honored right where they are and in the moment. At Clark, dementia is not a bad word or a word that we fear. It is a word that we are learning to embrace, and each one of us is embracing as one of our passions. I know that each one of you have come here today for a reason, and each and every one of you has a different reason for coming, and that reason is very important to us. So as we get started today, I would just like to introduce our panelists to you, and then we're going to throw it open to questions, because your questions are why we are here today. And we want to be able to spend the time answering and listening in on your questions and having the panelists hopefully answer and then chew on them a little bit with us. So our guests today are Dr. Al Powers, an international dementia educator and author, Mary Beth Tupper, a local geriatrician with Spectrum Health Medical Group, Joy Spahn, the Regional Director for the West Michigan Alzheimer's Association, and Chris Simons, the Director of Dementia Services at Clark Retirement Community. So we welcome the four of you to our panel today, and thank you for being with us today. So since I have the mic, I'm going to ask the first question. And this question is for Dr. Power. Dr. Power, how do you think institutions can start changing to develop a model of well-being and be that the model of care that leads the institution?
I'd like to just say a few things because when I do education sessions, sometimes we talk about a lot of things and people come away and they think, oh, it's so overwhelming, where do I start? And I think the first place to start really is to start by having conversations. Have conversations with the people you work with, have conversations with people that live at your communities, and in particular have conversations with people who live with Alzheimer's or other kinds of dementia and really hear their voices and hear their experiences. I consider them to be the true experts. None of us knows what it's like to have this change in our brains except those of us who have lived with it. And I'm embarrassed to say that for too much of my career, I didn't pay enough attention to what they were saying to really understand new ways of supporting them and caring for them. And also to understand that, to see the whole person, and to start, what are the simple things? There are two simple things I do in my workshops that I think are good places to start. So I'll just explain them quickly. One of them is I start with a get-to-know-you exercise, and people sit at tables, and I say, start by introducing yourself, but before you do, I want you to write down, suppose a time should come in your life when you could not speak for yourself. What are 2 or 3 important things about you would want other people to know? And I have people introduce themselves to each other that way instead of their job title or whatever. And we find out things about people that maybe we didn't even know about our coworkers. And we remind people that the things that are important to us don't really change that much, even when we live with a condition like Alzheimer's. So if you're someone who does not like noisy, chaotic environments, as a 25-year-old, chances are when you have Alzheimer's, you're not going to like that either. If you're someone who finds comfort in music that's grounded in your religion, chances are you will find comfort in that later. And understanding that knowing the whole person is so important, and making sure that we do know people as well as we should. And then the second thing I always tell people to start with is talking about language, because I think language is so powerful. And the way we speak makes us think in certain ways. Advertisers have known this for generations. Words make worlds is the expression that we use in Need an Alternative. And so we start talking about what are the words we're using, and do we use words that actually validate and respect the person, or do we use words that diminish and actually dehumanize the person? And do we use words that make us think in certain ways and blind us to new ideas? If we call a person's expression of need a behavior problem, then we're immediately saying that that is their fault because they have a disease, and you immediately have no chance of finding another solution because you've already put that on that person and pretty much closed the door to the idea that maybe there's something about the person's environment, the approach to care, or unmet needs that could be causing them to respond the way they do. And so it's very important to start challenging the words we do and realize that that we use, and realize that they really do change the way we think. So those are two ways that I start, and there's many more I could spend time on.
This is pretty basic, and probably everybody here besides me knows the answer to it, but Alzheimer's is a type of dementia. Is that true? I think that a lot of people express if somebody has any kind of dementia, it's Alzheimer's. Does that make any difference?
Give it to the pro over there.
So the
You
question
get this
is,
a lot, I'm sure.
Guess who got the microphone?
I'm sure you've
Joy,
never
just
heard that
make-
question before.
Never. Everyone heard the question, I'm assuming. The question was, is there a difference between Alzheimer's disease and dementia? And yes and no. And you're right, that the terms are used synonymously these days and interchangeably. But there's no disease called dementia. Dementia is a group of symptoms that's kind of an umbrella term. So there are many things that can cause dementia, and Alzheimer's disease is the #1 cause. There are over 100 things that can cause cognitive changes, so Alzheimer's disease is the #1. Vascular dementia is #2, and that's associated with like the TIAs, mini strokes, things that are happening in the brain related to changes in those kinds of things. Lewy body dementia, so there's a whole host of things that can cause those symptoms to be apparent. But Alzheimer's disease and dementia, so they're kind of the same, but Alzheimer's is a cause of dementia.
Thank you.
The other thing I would like to add just quickly though, and usually when I talk to folks about dementia, I tell them think of it more like a spider web as opposed, because we have a tendency to think in a linear way of dementia, that forgetfulness obviously is one of the first things that we notice because people forget things. And by the way, just because you keep losing your keys doesn't mean that you necessarily have dementia. Or that you forget the name of the person that you're getting ready to introduce. It's, embarrassing, but it's not fatal. So anyway, I tell folks, kind of look at it from a spider web approach. Because we also have a tendency to think of someone with dementia at the later end of the disease. And I always tell folks there's a whole lot of living that has to take place between the time a person realizes what's going on and the time that they need a lot of help. But from the time that we're born, we don't come into this world with a whole host of predetermined kinds of skills. We learn those things as we get older. We learn how to take care of ourselves. We learn how to walk. We learn how to drive a car. We learn how to not to talk back. We learn how to behave in church. So we have a lot of social skills that we develop. All of those things are based in memory. So when someone starts responding differently than what you would expect to a situation, or maybe when somebody has more difficulty controlling their temper or their impulses, or all of those kinds of things that are all learned behaviors as we grow up, and we learn those things, those are all part of the changes that are affected when someone develops a dementia, regardless of whether it's based in Alzheimer's disease or one of the other causes. Did that answer your question? Good. I'm done.
Wow.
is Alzheimer's able to be diagnosed in the moment, or do you have to wait until an autopsy is performed?
You can definitively diagnose Alzheimer's disease with an autopsy. You can also definitively diagnose it with a brain biopsy. If you have symptoms of Alzheimer's disease, I don't recommend a brain biopsy. Really, it's not going to change what we do. Probably 99.9% of the time, it won't change things, and it may cause more damage. We really base our diagnosis, it's a clinical diagnosis. Dementia is a clinical syndrome, as Joy pointed out, and we look at the different types of dementia based on the pattern of dementia. What areas of the brain are involved? Is it language? Is it your spatial skills? Is it your executive and your planning skills? Is it your motor skills? Are there hallucinations involved? So we're looking at different presentations to try to determine the type of dementia, but we are also not only looking at what has changed, but what is still there and what are the strengths, so that we can adapt successfully to the changes that are happening in the brain and educate the people that are affected as well as their families about how to adapt to these changes.
I've read several things about the medications that are used to treat dementia, Aricept and Namenda, among others, and I'm just wondering what your take is on the effectiveness of them, in spite of the great costs that they are.
So the question is about
Or if there is any data even about that yet.
You probably have four opinions about that.
the question is about the medications that are prescribed for individuals with dementia, Aricept being one of them, the high cost associated with those drugs, and is there research that backs that up?
There's always research from your pharmaceutical companies that are producing the drug about how effective they are. They will do studies that will look at changes in scores that measure some cognitive skills or performance skills, and sometimes we might see a change in those scores, sometimes an improvement, or instead of a steady decline, we may see a tapering off for a while, but eventually it continues to decline. I think people have to weigh the cost. They have to look at, are there side effects? Are there interactions with other medications? I see some people, and again, this is anecdotal from my experience, some people, we really see a bump up. Families notice that they're thinking more clearly. They're remembering events. And usually this tends to be earlier in the onset of the disease. They aren't very effective as the disease progresses. Drug companies are coming out with newer formulations, so once-a-day dosing or combination pills. I think that's a good strategy for them to make more money. I don't think that it ultimately changes the outcomes for people and the families. And I think that you can probably get a lot more bang for your buck if you look at other types of changes to engage in activities, meaningful activities, respite care for caregivers. So I'm a much more in favor of looking at spending our dollars on care as opposed to drugs for most of these conditions.
Al, do you want to also respond to that question?
I mean, there are a lot of different opinions about this, and depending on who you talk to, some people think they're great, and some people think they're worthless, and then there's all the gradations in between. And I'll give my personal opinion, but there may be other opinions too that are worth hearing. And it's not too different, really, from what Mary Beth had to say. In my experience of using this, I've found that some people find that they derive benefit, but not everybody. One of the neurologists I work closely with used to explain it by saying that it does not stop, slow, or reverse any changes. What it does is, when it works, it may set the clock back 6 months or so, 6 or 8 months. So if it's May and it works for me really well, I might start thinking the way I was last October, but it doesn't stop there. You continue to have about the same curve of change over time that you had before. And you know, you would think, well, if I could buy 8 more months of living a certain way, that's worth it. But there's been no evidence that this delays movement to nursing homes. So the evidence hasn't been really strong. There are numbers, as Mary Beth says, that are statistically significant, but they don't always translate to a meaningful change in your life. I'm not, many of you know I wrote a book called Dementia Beyond Drugs. I was not specifically referring to these drugs. If people and their families want to try them, I'm always willing to give it a try, but I just make sure I have a conversation so people are realistic about what you can and cannot expect from them, because some people expect them to be miracle drugs. And personally, my feeling about these new combinations, not only is it a sort of a ploy, but I feel like this area, which is what we call cholinesterase inhibiting, I think we've done all we can do with that. I think the next big breakthroughs in Alzheimer's are going to be in a whole different kind of approach. And I think we got to stop spending money on that kind of pill and making more Me Too pills and come up with a whole different approach, because there are many, as I'm sure Joy knows, there are many exciting areas of research for other totally different approaches that may be much more effective than this whole family of drugs. Do you want to say anything else about that?
While we're on the drugs, what about the cannabinoids?
What about cannabinoids is the question. I don't know enough about cannabinoids in dementia. Or what specifically symptoms are you looking to
I've read
treat?
some, the old internet, there are some studies and research in Switzerland. And,
Yeah, for distress or for cognitive change? That's the
just
question.
For the dementia person, it helps a lot of the combativeness.
Yeah,
and the,
yeah. There is no
are
other.
the ones that the CBCs that take the psychotropic part of it out of it, and they're having a lot of success.
Yeah, my feeling is that they're still barking up the wrong tree because there's a whole broken paradigm here, and antipsychotic drugs are getting a lot of bad press now, and there's no question that they are bad actors for the majority of people. But the problem is not the antipsychotics per se. The problem is the mindset that says the person is distressed needs a pill or a drug to calm them. What these are mainly doing, whether it's a cannabinoid or a Seroquel, is they are sedating people. People that have schizophrenia have high dopamine levels, so blocking dopamine makes sense. People with Alzheimer's tend to have lower than normal dopamine levels. So there's really no chemical basis for using these drugs. What often happens is people have an unmet need that they can't communicate. And instead of trying to find out what that need is, we medicate them. So my feeling is, whether it's the Seroquel family or the Ativan family or the cannabinoids, they're all the same broken way of thinking that a drug is going to give a person well-being when there are certain things that you cannot bottle. You have to change the care environment.
How many different types of dementia there are, and if you deal with the different types of dementia in the same way?
Well, you give me the easy one, huh? Okay. In all honesty, I don't have an exact number of how many different causes of dementia that there are, because that can be contributed to a number of different factors. Someone that's had a head injury, someone that has something like an Alzheimer's, so depending on the nature of the changes in the cognition. In terms of approaches and treatments, there are some changes, or there may be some variations in how that process is experienced by the person. So for example, with an Alzheimer's disease, often you'll see, like Dr. Powers mentioned, just kind of a gradual decline. Someone with like a vascular dementia, you may see sometimes a little bit more of a stair step depending on when that activity is occurring in the brain. The result of that is some gradual declines overall. So I'm not aware that any of the dementias that we work with at the Alzheimer's Association actually stops at a certain point. Maybe you have some more information about that?
No, the only one that, if you have something related to a stroke, it's possible it might stabilize for a long time if you don't have more strokes. But,
Right.
but that would be about the only one that I think. But each person's individual, and people don't change a certain way because they have, each person's individual. So just because they have a certain form of dementia doesn't mean they're going to act like somebody else who has the same form or a different form of dementia. It's very much an individualized thing. So I guess I'll leave it at that because I see a lot of hands up. I'll give it to Mary Beth.
From a physician standpoint, what we try to do if somebody has a vascular dementia is control those factors that put them at risk for more strokes. So good control of blood pressure. If they have atrial fibrillation, trying to prevent clotting forming in the heart. If they have diabetes, trying to have reasonable control of diabetes. And I say reasonable because that changes as people get older. We are not looking for tight control. We found out that that actually can be worse for older people. If their blood sugars are too low, that too causes brain damage. A big factor in our society, we're going to see people coming back from wars where they've had explosive devices, coming back with brain injuries and post-traumatic stress that leads to cognitive impairment, and substance abuse that leads to cognitive impairment. And I will also mention painkillers, a huge contributing factor that might be reversible if we can get people off the painkillers and a less toxic analgesic program for people. So medications are a big cause sometimes of cognitive impairment that we need to really pay close attention to, particularly in elderly individuals.
Sometimes what we see, particularly in facilities like this that people may have a bladder infection or a tooth that has a problem. And when that occurs, it heightens their dementia. They're more confused, and until we address those issues, things don't change for them. So there's all sorts of things that can cause a change, but the infection is a big one that we look out for.
You can also have more than one cause of dementia going on at the same time, so one does not preclude the other. So back to the question of the course of it, there's no predetermined course that it's going to take, because there's so many factors involved with it, which is one of the challenges of coming up with something that's going to treat it effectively. Because there are other components, it's just not so straightforward. So looking at the overall health of the person, the age of the person, what other kinds of health issues do they have going on? Are the kinds of things that Dr. Tupper talked about, are those under control? The diabetes, the heart conditions, all of those kinds of things are going to have an impact and an influence on how the disease progresses.
Dr. Power, you talked about a broken way of thinking.
Yeah.
As an educator working with nursing home or skilled facility environments, how do you change that way of thinking with staff, and do you have specific interventions that work best?
Yeah, well, what I'm doing now is actually working in another home. What's that? Oh, I'm sorry, repeat the question, yeah. Do I have specific ways of teaching this idea of changing the way we think? Do I have any specific interventions that work best? What I have done is I've really tried to tear down all the things that we've learned about dementia and try to come up with another model. And I don't do it to reject everything that we've learned or to be unscientific, but I think that while it is very important for drug researchers to know everything about plaques and tangles and chemical changes, I think that what happens to most of us when we get infected with that way of thinking is that the more we see plaques and tangles, the less we see the person. And we start blaming everything on disease and doing what Tom Kidd would call positioning, just expecting someone to act that way because they have this label of dementia. There's a lot of stigma that comes with that. There's a lot of prejudgment and lowered expectations. And so I went back and just defined dementia in a very simple, kind of flaky way. I just said dementia is a shift in the way a person experiences the world around her or him. And there are two things about that. Number one, there's no judgment or stigma associated with it. We're just changing the way we experience the world. And number two, that experience is important. We have to understand from the point of view of the person what's going on. And so I really try to take people through a lot of challenges about what they are seeing and say, is that really true? Could you see it this way? So I do a lot of paradigm shifting exercises to take people through that, and then try to introduce this new definition and show how that leads you to see things in different ways. And lots of stories, lots of examples, lots of exercises that we could spend an hour on, but that's how I started.
I could add to that. Certainly, one of the methods that we use at Clark, I have taped several of our residents that have memory loss, and actually having them see some of the people they know explain what it's like to have the dementia. Then they have a different perspective on what they do with the residents and how they feel about them. And I think visual things that they see or hearing actually have some folks with dementia talk to them. We've done a lot of, at the beginning when I started 10 years ago, we talked a lot about dementia and what it is, but now I touch on that lightly and then I go right to, how would you feel if today you were diagnosed with Alzheimer's? And they're like, well, we couldn't be, we're young. I said, well, that's not necessarily true. And then how would you want your family to treat you? And what are your biggest fears about getting dementia? And then it's a whole different story for them. And we start that right at the beginning at orientation. And I think that has made a huge difference for us, because you gotta hit them in the heart right at the beginning and start moving them from the beginning. And the other thing we're doing, we've hired a company to do coaching with us that deals with communication and all sorts of things, and I think that's going to be real helpful. And today we had an opportunity for our frontline staff at lunch to eat with Dr. powers, and that really already I've heard from a lot of the folks that did that, to let your frontline staff have accessibility to someone who has written a book or someone that has a different perspective and is a thought leader or whatever. It builds their self-esteem, and they want to do a better job, and they understand that it's a better way to do a job. You feel better about yourself versus always having to get the task done. So that's how we've done it, and we've been pretty successful with it.
Piggyback one more story on that. I think when you mentioned interventions, I have a kind of a provocative heading in the prologue of my new book, which is Why Non-Pharmacologic Interventions Don't Work. Now, you might think that that's strange coming from a guy that wrote a book called Dementia Beyond Drugs, but a lot of it, once again, is the mindset of how we provide interventions. They tend to be reactive, not proactive. They tend to respond to the stress but not understand what's beneath it. They tend to be not individualized or person-centered, and they're often treated like doses of pills, so pet a cat TID before meals or something like that. I heard a great story that I think really heads up why the intervention approach doesn't work for us. And it was a gentleman in rural Iowa who had moved into an assisted living, and he kept trying to go out the back door. And the staff kept redirecting him, and the more they redirected him, the more insistent he got. And of course, they tried to do all kinds of things, and nothing worked. And finally, the administrator said, listen, we have a fence out there. He's not going to get in trouble. Just let him go and see what he's doing. And he walked out the door, and they let him go and stood at the door and watched him. And he went to the back fence, and there was a pasture with a herd of cows. And he stood there and watched the cows for about 15 minutes, came back in, sat down, and he was fine all day. And when they got to know him, he was a farmer, and every day he started by checking the cows. Now, the problem with interventions is that our usual approach to someone trying to leave is, let's try folding washcloths. Let's try some music. Let's try an activity. He needed to check the cows. And all those non-pharmacologic interventions are worthless if you don't know the individual and what's driving the behavior. So once again, it's still where my idea is that when we try to do these non-pharmacologic interventions, we're still doing person-centered care with a biomedical mindset. We haven't really made the paradigm shift. And so that's why my new book really focuses on a strength-based approach of creating several domains of well-being and working at what's underneath it